Good morning, everyone. My name is Hameed. I'm one of the consultant radiologists here at the Norfolk and Norwich. I'm going to show you some interesting cases and also teach you a little bit about how to look at CT scans, which I think will hopefully prove very useful to you guys. I apologize, I've got a bit of a cold, so my voice sounds terrible. I hope I don't lose my voice in the next hour, but if I do, that's why. So essentially what I'm going to do, first thing is teach you a little bit about how to analyze CT scans, and then we're going to look at some fun cases, just to give you a taste of what to expect, when you hopefully all become radiologists in the future. So this is a CT scan of a 64-year-old patient. The very first thing to really understand about CT is obviously how CT scans are required. So CT scan, effectively, put it very simply, it's an X-ray that's taken at 360 degrees. And you then put all of those X-rays that you take into a computer, and the computer spits out an image. That's a very, very basic form of how CT scans are acquired. And just like an X-ray, anything that is dense, such as metal or bone, will appear white. Anything that is not dense will appear dark. But in truth, the density of a structure is represented in something that we call Hounsfield units. And it's quite easy to sort of get on a CT, because you can just draw a little circle and it'll actually tell you what the Hounsfield unit value of anything you're looking at is. So here you can see HU is Hounsfield unit, M is mean. So the mean Hounsfield unit value here is minus 999. And that's because air is around about minus 1,000 Hounsfield units. Now, this is a really useful thing to understand because it helps you to understand what kind of tissues you're looking at. So the first thing you need to understand is Hounsfield unit values. So different tissues have different Hounsfield unit values. So air is around about minus 1,000. Fat is usually around minus 100. Fluid is between 0 and 20, usually. Soft tissues will be over 20. Bone will be over 100. Obviously, you've got cancellous bone, which will be much lower density than cortical bone. As you can see here, the cortical bone here is 663. And then metal will be over 1,000. So you've got quite easy numbers to remember. Minus 1,000 for air, minus 100 for fat, 0 to 20 for fluid, over 20 for soft tissues, over 100 for bone, and over 1,000 for metal. And this is really useful because if, for example, you are looking at this thing here that's hanging off the right kidney and you want to know what it's made of, you just simply draw a circle. And that is around about, let's see, what is that? It's about, what, minus 10 Hounsfield units, which is close enough to 0. Therefore, that contains fluid. Therefore, it is a cyst. And that's basically a very simple way of how we diagnose things in organs. If the Hounsfield unit value is 0 to 20, then that's going to be something like a cyst, as long as it's nice and homogeneous. So understanding Hounsfield unit values and how they relate to different tissue types is the first thing you need to understand. The second thing to understand about CT is how those Hounsfield units are converted into the image that you look at. So we've got thousands upon thousands of different Hounsfield unit values, ranging from minus 1,000 all the way to plus several thousand. But our eyes can only really see 20 different shades of grey. So there's no point having a shade of grey for every single Hounsfield unit value because you just won't see anything. And what you really need is you need to group those Hounsfield unit values into 20 different shades or so of grey so that your eyes can actually differentiate between the different tissues. And the way that you group those Hounsfield unit values is something we call windowing. You may have heard this term before. Lung window, soft tissue window, brain window, liver window, that kind of stuff. You may have heard those terms before. That's basically all it really means is how are you grouping these Hounsfield unit values? So here, for example, you can see we're in a soft tissue window, and that's why you can see the liver really nicely. You can see the fat here. I can tell you it's fat because I can draw a circle around it, and there you go, minus 100 Hounsfield units. You can see the fat around the organs. You can see adrenal glands. You can see spleen. You can see kidneys. You can see the soft tissues really nicely. But if you try and assess the lungs, you can't really see much detail in there at all. And that's because the lungs are very, very low density. And we've run out of greys. So everything that's a very low density, less than minus 200, for example, is just going to be black. And all of our grayscale is focused in on the soft tissue range. If we want to have a look at the lungs, we use a lung window. And so what I've done here, all I've done is basically change the way that those Hounsfield unit values are converted into grays. So now you can see beautiful detail within the lungs. You can see all the vessels, you can see the bronchi and the bronchial walls here. And you can see the lung parenchyma. You can see if there are little nodules, like this tiny little thing here, for example. So you can then assess the lungs. However, what that then means is that everything in the abdomen now looks rubbish. It's all just white. Because again, all of our grayscales are focused in on the range that you get in lung. And what do you think you would do if you wanted to look at the bone? Where would you focus your Hounsfield units or your grayscales? Seeing if anyone puts anything in the chat. This is something called a bone window. So what we do is now we're doing the opposite of what we do for the lungs. So we're focusing our grays on all the higher Hounsfield unit values. And you'll notice on the normal soft tissue window, you don't really get to see much detail in the bone. As soon as I put it on the bone window, suddenly you can see beautiful cortex, you can see medulla. If there's a little lytic lesion, you'll be able to see it really easily. And that's because all of our grays are focused in on the range of Hounsfield units that you get in bones. And the soft tissues look rubbish because they're all dark and almost black, because that's basically what happens when you're using a bone window. We've got various other windows as well. Got a liver window that sort of focuses on the liver and makes everything else just rubbish. Got a brain window, which is completely useless in the abdomen, understandably. And you've got a variety of other windows as well that we use. So concept 1 is understanding Hounsfield units. Concept 2 is understanding how those Hounsfield units are converted into a grayscale and why we use different windows for different tissues. And concept 3 is understanding contrast and what it is. So I'm talking not about contrast in the image, I'm talking about IV contrast. IV contrast medium contains a lot of iodine. Iodine is quite low down the periodic table, therefore it is very dense. Anything that is dense is bright on CT and plain film. So if you inject someone with iodine-based contrast, the organs that the contrast ends up in will enhance, which means they will get more dense. So here, this is a nice scan because we've actually got what we would call a sort of triple phase study. So this is unenhanced. There's no contrast here. You can see the aorta is sort of gray, like almost like soft tissue. This, you can see the aorta is now bright. And that's because there's lots of contrast in the aorta. This is what we call an arterial phase. So the next concept to understand is the concept of contrast phases. So we have injected contrast into the patient's blood vessels. And the timing of the scan after you inject the contrast is critical because you time the scan depending on what organ you are interested in. So let's say, for example, you wanted to look for pulmonary emboli. So you're interested in the pulmonary arteries. So you wait a very short period of time. The contrast is injected into the veins. From the veins, it gets into the SVC, into the right side of the heart. The first place it goes to after that is the pulmonary arteries. So if you want to look at the pulmonary arteries and you're looking for filling defects or clots in the pulmonary arteries, that's when you do your scan, very, very quickly after you've injected the contrast. But here we're looking at the abdomen. So we're not so interested in the pulmonary arteries. So we're going to wait a little bit longer. So we wait longer, the contrast goes into the pulmonary arteries, into the pulmonary veins, back into the left side of the heart, and then out into the aorta. And that's when you do your scan if you want an arterial phase. And we call it an arterial phase because, unsurprisingly, the arteries are very bright. And this is roughly around about sort of 25 to 35 seconds or so after you've injected the contrast. And you can beautifully see all the vessels. So if you're worried, for example, about arterial bleeding, if you're worried about arterial ischemia, like a blocked artery, something like that, or you're worried about aneurysms and that kind of stuff, that's when you would do your scan. Most abdominal scanning that we do, however, is done in the portal phase. Now, you may have heard of this term before and may have seen it in radiology reports. The portal phase basically is a bit later. It's about 60 to 70 seconds. And by that time, the contrast has gone out into the aorta, into the SMA, into the bowel, and it's coming back to the liver via the portal venous system. And that's why it's called the portal venous phase. So this here is the portal vein here coming into the liver. And you can quite nicely see there's lots of contrast in it, and it's ever so slightly brighter than the aorta. So when you're looking at a CT scan, it's important to understand what phase you're looking at, because the pathologies you'll be able to identify will differ depending on the phase. Most abdominal scanning is done in the portal phase, but there are occasions where we might want to do more than one phase. In this case, we've done a triple phase. And a triple phase scan is done in a variety of different settings. Sometimes it's done to characterize liver lesions or pancreatic lesions, things like that. But in this case, this is an acute presentation. This is a patient who presented with GI bleeding. And in a patient with GI bleeding, we want to identify where the bleeding is coming from. And so a triple phase is very useful because this helps us to identify what's going on. So I'm just zooming in on the area of interest here. So essentially what we've got here is on the arterial phase, you can see a blush of contrast here in the colon. This is the right colon here, and you can see a blush of contrast there in the ascending colon. And then later on the portal phase, another sort of 20 seconds later, you can see the blush of contrast is now pooling. This is active bleeding into the colon. You can actually see a jet of contrast here as well coming into the colon there, and this turns into a little puddle on the portal phase. So that tells you this patient is actively bleeding. Why do we do a pre-contrast? Well, people can have dense stuff in their colons, tablet fragments, foreign bodies and things that they may have ingested, etc. And so you need to do a pre-contrast because you want to make sure that the density that you're seeing post-contrast was not there pre-contrast, and you can quite clearly see it was not. So this is not a tablet fragment or anything like that. This is genuine contrast extravasation. This is contrast that should be in the blood vessels, not in the blood vessels, inside the colon instead. And this is active bleeding. And so we've now diagnosed exactly where the patient's active GI bleeding is coming from. The next question is going to be, well, what's caused it? As a radiologist, you know, one of the things that's sort of most fun is trying to delve a bit deeper. So why is this patient bleeding? You know, what are the things that can cause bleeding? So we can look for various causes. So what are the common causes that can that cause bleeding? Well, you might be thinking of things like diverticular disease. So you might look for diverticular. Can you see any outpouchings coming from the colon in this location? Well, not really. The colon looks fairly nice and smooth. Tumors. Can you see any irregular wall thickening of the colon in this area? That, you know, because tumors can bleed as well. Well, not really. Again, it looks fairly nice and smooth. So there's not really any obvious cause for this. And so what do you think the underlying cause is likely to be if we can't see anything? See if anyone posts it in the chat. Have a bit of tea while we're waiting. So thinking about common causes of right-sided colonic bleeds, we've excluded diverticular disease, we've excluded tumors. So, yeah, we talked about diverticular. So there's no obvious diverticulum coming from this location. So one of the really common causes in this age group is angiodysplasia. There we are. Well done, Katie. Yep, absolutely. So this was an angiodysplasia, and that was the cause of the bleed. And that's a small vascular malformation. The vascular malformation itself is too small to see on imaging, but when it bleeds, you can see it, and you can see the bleed coming from it, and that's basically what's causing this. So, so we've gone through Hounsfield units. We've gone through windowing and how that works. We've talked about contrast phases. There are other contrast phases as well that I haven't mentioned. So, for example, if you're interested in the ureters, you would wait 5 minutes, and then at 5 minutes, contrast that's in the blood starts getting excreted by the kidneys, and then you can actually see contrast in the ureters coming down. So, you know, you've got you can then see the ureters, see if there's any urothelial tumors and things like that. And there are a variety of other sorts of contrast phases that we use, but these are the sort of basic ones. So the next thing to understand about this is the concept of inflammation. So a lot of CT scans that we do of the abdomen, we're looking for an itis, whether that's a cholecystitis or a pancreatitis or an appendicitis or a diverticulitis or whatever kind of itis that we're looking for. And the important thing to understand about any kind of inflammation is that all of our organs are surrounded by fat. Inflammation makes vessels leaky. Leaky vessels leak fluid. And so if an organ is inflamed, you get fluid leaking into the fat around the organ. And that leads to something called fat stranding. You may have, again, seen that term in radiology reports and wondered what it means. That's basically what it is. It's edema or fluid, strands of fluid usually, in between lobules of fat. And basically, the organ that's surrounded by the fat stranding is the organ that's inflamed. It's basically as simple as that. CT is actually, I think, the easiest modality to understand in radiology. So what I'm going to do now is I'm going to show you this CT. I'm going to scroll through, and I want you to look at the fat, and I want you to tell me when the fat starts looking dirty and fuzzy with little strands of fluid density stuff in it. So let's scroll down. I want people to say, I'm going to look out for the chat and see whether people can identify the fat stranding. On which side of the abdomen is it? Scroll down to the bottom, and I'm going to scroll back up to the top. So we're looking at the fat around the organs, and we're looking to see if any of the fat looks particularly dirty, fuzzy, with strands of fluid and that kind of stuff in it. Any thoughts? Right side, absolutely. So right side of the abdomen. Now, are we talking right upper quadrant here near the liver? Are we talking right flank near the kidney? Or are we talking right iliac fossa? Absolutely, right lower quadrant. Good. So next question. What are the common causes of inflammation of right iliac fossa? Without even looking at anything else, just conceptually, right iliac fossa inflammation, what are you thinking? Yes, appendicitis, absolutely. So that would be, yeah, everyone's saying appendicitis, which is good. So already you're pretty much there with the diagnosis, yeah, and you've not really done anything apart from look for some fat stranding, yeah. So that's good. So the next thing is, let's see if we can identify our appendix, shall we? So, what I'm going to do, I'm going to go up. I'm going to show you the hepatic flexure. Hepatic flexure is usually a relatively good anatomical marker. You see liver and gallbladder here. You know that's gallbladder because it's sort of fluid attenuation, and it's sitting under the liver there. Then right next to that, you'll find the hepatic flexure. You can actually quite nicely see these alstral folds here on the lung window. Lung window is actually not just used for lung. You can also look at use it to look for pneumoperitoneum, anything where you're looking for gas, basically. And you can assess the colon and stuff here as well. So that's hepatic flexure. If we're going to continue down from there, this is transverse colon, which as opposed to what you see in the textbooks, is rarely ever transverse. Usually loops down and then loops back up again. This is transverse colon going over to the left side up and there. So splenic flexure, which is close-ish, just clean. If we're then going in the other direction from the hepatic flexure down this way, we're going into ascending colon. The ascending and descending colon will usually have a fairly predictable location because they are retroperitoneal structures. So they do not flop about, unlike the transverse colon, the sigmoid, and the cecum, which have a habit of flopping around because they're intraperitoneal. So they're on a mesentery. So ascending colon coming down. And what we're looking for is we're looking for a couple of things. Firstly, is there wall thickening? You can see the wall here of the ascending colon. This is kind of pretty normal. This is kind of normal transverse colon here. You can see ascending colon maybe ever so slightly thickened. But we're looking for wall thickening. And as we're coming down the ascending colon, you might notice here that the wall gets very thickened as we go down. Next thing we're looking for is the ileocecal valve. And the ileocecal valve is where the terminal ileum comes in. Usually it contains a crescent of fat. You can see here, there's a little crescent of low density in there. The density values here range from around about -37. And usually if you've got any little spots, actually there's sort of spot of -50 there as well. If you see a little spot that's less than sort of -20 or -30, you can say that there's probably going to be some fat in there. And you can see here, there's some very low density in there. So that's a bit of fat in the ileocecal valve, which means that this little thing poking up the side is terminal ileum, which you can actually follow down here, and it goes down into the pelvis. So we've identified the ileocecal valve. You're beginning to get excited now because you're like, okay, I've got the ileocecal valve. Next is going to be the appendix. Appendix usually comes out a couple of centimeters below where the ileocecal valve comes out. So you follow the cecum, which by this point is very thickened with lots of fat surrounding around it. And you're going down and you're looking to see if you can see a tubular blind ending structure. Well, these bowel loops here will contain gas. This is a funny bowel loop here because it contains just fluid. So let's have a look at that. Can we follow it? Well, that seems to end, doesn't it? It just seems to disappear off to nothing. And if we follow it round, you can see it then continues up and then you sort of end up in cecum. So this is the appendix. It's a blind ending tubular structure in the right iliac fossa coming off the cecum. Normal appendix is 6 millimeters or less in diameter. This is nearing 2 centimeters. So it's quite clearly thickened and it's got lots of fat surrounding around it. So we have now diagnosed acute appendicitis. Well done, everyone. So, as I said before, as a radiologist, one of the really important things that you can do, which other sort of clinicians don't do, is to dig a bit deeper. So are we happy with just calling this acute appendicitis, or are we going to be then looking for complications and looking for other things that that might be going on? So let's have a closer look at this appendix. So remember what I was saying about contrast. It's intravenous, and organs which are supplied by contrast, supplied by vessels, will get brighter and they will enhance when you give IV contrast. If you've got an organ that's inflamed, there's vasodilatation, it will get more contrast and therefore it will enhance more, which is why if you look at the wall of the appendix, it looks brighter than the wall of, so say, these bowel loops here, okay? And that's because it's inflamed, right? However, what then happens if you get gangrene forming? So if you have like a gangrenous appendicitis, or if you have like a perforated appendix, what would happen to the enhancement of the wall? Well, gangrene effectively means that there's no blood flow going to it. If there's no blood flow, there won't be any contrast. So you will lose enhancement. So if we're following this appendix here, and we're looking at it, you can see enhancement of the wall all the way around. What happens to the wall as I am scrolling up to here? Can we still see the wall as a clear structure? The answer is no. And that's because the base of the appendix here is gangrenous. So we've now upgraded from acute appendicitis to acute gangrenous appendicitis. The next question is, has it perforated? If you, interestingly, follow the line of the appendix, you imagine that the appendix is here, although you can't see the enhancement. Follow the line of it, you might notice here, it's a big old dent thing in the appendix there. So what could that be? We saw in the previous case that a blush of contrast can look a bit like that. So is this active bleeding? Or is it something dense that if we had done a pre-contrast phase, we would still see as very dense? Well, this is most likely something that is already there, something that is dense. And this is something we call an appendicolith, which I'm sure you guys have heard of. So this appendicolith has basically obstructed the orifice of the appendix, and that is the cause of the appendicitis. So next thing, if this is an appendicolith stuck in the appendix, and this is the appendix that's inflamed, then what about these dense things here? Because these dense things aren't in line with the appendix. The appendix comes up this way to the appendicolith, but these things are outside of that. And they're also outside of the cecum, because the cecum is all the way up here. So what are these? Well, these are also appendicoliths, but these are appendicoliths that have spilled out into the peritoneal cavity. And the fact that they've spilled out into the peritoneal cavity, and we've got a little collection here as well, also then upgrades this from a gangrenous acute appendicitis to a perforated gangrenous appendicitis. So you can then tell the surgeon that it's already perforated, which again can be useful to the surgeons. So this is kind of what I mean, as a radiologist, you don't just stop at, oh yeah, this is appendicitis. You want to go the extra mile and actually give a lot more information if you can. And this is a really nice sort of demonstration of that. Any questions on this before I move on to the next case? Okay, good. Right, let's look at something else. This patient, I'll just look at the portal face for this patient. So the first thing you might notice, looking at this patient, is that they don't look very well. here we are in the lungs. Yeah, see lung windows. You can see beautiful lungs here. But at the back here, we've got a little bit of atelectasis, a little bit of partial collapse of the lung. And then here we've got this stuff, which if I measure it, is around about, what, 8 Hounsfield units, something like that, minus 8 Hounsfield units, so close enough to 0. So what do we think that is? This stuff here at the back. Any thoughts? Fusions, absolutely. So we've got a patient who's got bilateral pleural effusions. They've also got here, what do you think this structure is behind the heart? This is the heart. That's the aorta. What do you think this structure is? Following it down, comes into here. It also contains fluid. Esophagus, absolutely. So this is the esophagus. And you can see the esophagus is fluid filled. You can see it leading down to the stomach. And then within the esophagus, you can see this little tube. So this is an NG tube. And you can also see that the NG tube comes down, and then loops, and then goes back up again. So the first thing you want to put in your report is this patient has a misplaced NG tube. And you can kind of almost actively see them refluxing because you can see all the fluid in the esophagus. Normally, the normal esophagus is collapsed. So the first thing you would do is get them to recite the NG tube. And this is before we've even got to what's actually wrong with the patient. So again, this kind of comes down to, as a radiologist, one of the really important things is looking for those other things that other people won't look for. And identifying a misplaced NG tube can be very important. So next thing, we're going to go down, again, just like the previous case, I'm going to ask you to tell me where you think the fat stranding is and where you think, which organ do you think is most inflamed. So I'm going to go down and we're going to have a look and we're going to see where is a lot of the fat stranding. Now, this patient has quite a lot of fat stranding, which can make things a little bit difficult. But where would you say the epicenter of all this fat stranding is? See if anyone's got any ideas. So, well, pancreas, absolutely. Yeah, we've got a few pancreases. Yeah. So this is centered around the pancreas. Now, the pancreas is actually can be a bit of a tricky organ to assess on CT because its anatomy is less easy than some of the other organs. So just very quickly, liver is easy. Everyone can recognize the liver. Everyone can recognize the spleen. There's like a mini liver on the other side. Everyone can recognize the kidneys because there's 2 of them and they look kidney shaped. So there we go. This is the kidneys. And usually you can identify the adrenals because they sit on top of the kidneys. You can see them here. They're sort of arrowhead shaped structures. The pancreas is a little bit more annoying. And what I always sort of say to people when you're looking for the pancreas is actually follow the portal vein first. So here from the heart, we've got IVC coming down. You've got 3 hepatic veins joining the IVC. IVC then comes around the back here. And then anterior to the IVC, so in front of it, you've got the caudate lobe, which is this bit of the liver. And then in front of that, or just lateral to it, you've got the portal vein. And this is the portal vein here. You can see it splits into left and right portal vein going off into the liver. If you follow the portal vein back, you will see it do another split. And it splits into the splenic vein, which goes off to the left, and the SMV, or the supramesenteric vein, which goes down to the abdomen and goes off into the bowel. If you're looking for the pancreas, the easiest way to do it is to follow the portal vein down, identify the splenic vein. And once you identify the splenic vein, you've basically found the pancreas because the pancreas is stuck to the splenic vein onto its surface. So anything that's anterior or superior to the splenic vein is pancreas. So all of this tissue here is pancreas. You can see pancreatic tail coming up towards spleen. You can see pancreatic body. Pancreatic neck is this section of the pancreas just in front of the portal confluence, which is where the SMV and splenic vein join. Pancreatic head is to the right of the SMV and portal confluence. And the uncinate process is the bit of pancreas that pokes behind the SMV. What do you think this little dark tubular structure going through the pancreatic head might be? I'll give you a clue, it's fluid density. And it goes up to the liver. Any thoughts what that tubular structure might be? Yeah, absolutely right. CBD. Good. That will become important. So, we've got pancreas, and you can clearly see that a lot of the fat stranding here is centered around the pancreas. But this patient also has lots of fat stranding extending into the root of the mesentery. They've even got lots of fat stranding here within the flanks and the subcutaneous tissues. They've got lots and lots and lots and lots of fat stranding. And this is basically explained because this is what pancreatitis does to you. You've probably heard of third spacing in relation to pancreatitis. And so this is basically third spacing. This is exactly what this is. It's when you get leakage of fluid into the extracellular space. That is third spacing. So, and pancreatitis, because it causes such a severe SIRS response, you get the systemic inflammatory response, you get leaky vessels everywhere, so you get third spacing of fluid everywhere. That's why this patient's got pleural effusions. That's why this patient's got lots of subcutaneous fat stranding in their flanks. That's why they've got loads of fat stranding extending into the mesentery, because pancreatitis causes a very severe SIRS response. This fluid should be in the intravascular space, but it is not. This is also the reason why pancreatitis patients get sick and they go into organ failure, because they deplete their intravascular volume, because all that fluid is now sitting here within the peritoneal cavity, and here within the flanks, and here within the pleural effusions. So another great thing about radiology is you can quite literally see pathophysiology in action. You can already tell just by looking at this patient. This patient is sick. They've got loads of third spacing going on, loads of fat stranding everywhere. So are we happy just calling this acute pancreatitis? Finishing the report there and ending? Well, no, as I've sort of gone through, it's a job of radiologists to go that extra mile. So with pancreatitis, one of the important things is, are we dealing with necrotizing or non-necrotizing pancreatitis? And if you're looking for necrosis within the pancreas, what do you think we're looking for? I mentioned it a little bit when we were talking about the appendix. What do you think the pancreas would look like if part of it was necrotic? What would it do when you gave IV contrast? Would it enhance or would it not enhance? Exactly, absolutely. So you're looking for lack of enhancement. Exactly, that's absolutely right. So this portion of the pancreas is enhancing quite nicely. Tail, body, neck, that's okay. The head here is enhancing okay, at least laterally. But what about this portion of the pancreas here? The uncinate process that pokes behind the SMB, all of this is still pancreas, but it is not enhancing. Yeah. So if it's not enhancing, it's not getting a contrast. If it's not getting contrast, it means it's not getting a blood supply. If it's not getting blood supply, it means it's ischemic or infarcted or gangrenous. This is necrotizing pancreatitis. And necrotizing pancreatitis makes patients far sicker than non-necrotizing pancreatitis. So that is why I labored that point about understanding contrast and exactly what it means, because it really helps you understand how we assess organs on CT. A bit further down, you can actually see the uncinate process then sort of recovers, but as you go up, you see this big portion of the uncinate process just disappears. You've just got this section of necrosis there. In addition to that, what else are we going to be looking for? Well, what are the common causes of pancreatitis? Gallstones and alcohol. Yeah, that's probably the two commonest, third being ERCP. Hopefully, you'll have a history if the patient had ERCP, though not always, and sometimes you have to hunt through previous imaging to see if they have had an ERCP or whatever. But we can look for gallstones. This patient, you can see, has got, well, I can't really see a gallbladder here. What I can see are these two very bright things. Density value over 1,000. What are they made of? Hounsfield unit value over 1,000. So stones will be similar to bone density. So they'll be over 100 Hounsfield units. Metals, absolutely. So if it's made of metal, what is it? Clearly doesn't belong in the patient. So if it was a tubular metal structure within the bile duct, then absolutely it could be a stent. Yes, this is a clip. Because what can't we see? We can't see the gallbladder. What can we see in the gallbladder fossa? We can see some metal. Therefore, these are cholecystectomy clips. And that's basically what they are. So those patients had a cholecystectomy. So clearly they had gallstones before. So it's possible that they've got Sorry, my voice is really going. It's possible that they've got some retained stones in the bile duct. Yeah, it's possible they could have some gallstones in there. So what do we do? Well, if you're looking for stones, stones are intrinsically bright, usually, not always. Roughly about 80% of the stones you can see on CT, not all of them. Luckily, we've done a pre-contrast here. And pre-contrast is obviously quite useful because the rest of the organs will be darker pre-contrast, whereas the stones will remain bright. So you will see the stones much more easily on a pre-contrast than you will post-contrast. You have to understand your anatomy a little bit better to follow the bile duct, because the bile duct will be a bit more difficult to follow. You can still just about see it here with the pancreatic head. But you'll be looking at that and seeing if you can see any stones in there. And I can't see any dense stones in there. It doesn't mean that there aren't any stones, because it still could be a radiolucent stone, but that's one of the things that we would look for. So when you're looking for, pancreatitis cases, you're also looking for the potential cause as well. And the other things you can look for are complications, because pancreatitis causes all sorts of complications. So this is the scan that was done 4 days later. You can see the patient still got some fluid effusions, loads of fat stranding still around the pancreas. You can see this little pocket of fluid here stuck between stomach and pancreas there. That is the lesser sac. So this is fluid in the lesser sac. And you can still see loads of sort of fat stranding heading into the root of the mesentery and all sorts. Let's see what happens next. These patients often have loads of scans. So another 4 days later, they have another CT scan. Let's see what that looks like. So again, fluid effusions, although the one on the right is getting a bit better. Still got, oh God, loads of fat stranding. Still, you can see how severe pancreatitis is. Look at the fat stranding in the flanks. Look at that presacral edema, in the back. Just all sorts of horrible, horrible sort of fat stranding everywhere. Now, you might not pick this up on this scan because it's relatively subtle. But if you look at this colon here, you might notice, again, looking at lung window, this is colon, right? So there's descending colon coming down into sigmoid, and then sigmoid colon going down in that direction. If that's all colon, then what on earth is that? There's a small gas bubble just outside the colon there. That's odd. Why does this patient have free gas? Well, let's see what happens on the next scan. The patient has another CT. This is, when is this? Another 4 days or so later. What's happened now? Oh, hold on a second. Put it back on lung windows. Now you've got free gas up here near the liver. Remember that gas rises against gravity. So free gas, a really good place to look is just deep to the anterior abdominal wall. You can see free gas here. A lot of free gas, a lot more free gas than there was previously. And you look further down, look at all that third spacing, look at all that stranding, fluid, and just horrible inflammation. Clearly not getting better. Look at the colon. Oh, what do we have here? You can see the mucosa of the colon, and then you can actually see gas inside the wall of the colon. This is pneumatosis. It's gas inside the wall of the colon. Look at that. Gas bubbles all scattered throughout the walls of the colon there. And then here, this is gas perforating through the wall and coming out. So this patient basically infarcted their sigmoid colon just as a complication of pancreatitis. And their colon basically fell apart and perforated. So again, this patient had a CT just as a follow-up for pancreatitis, probably because they were getting a bit sicker. And it'd be very easy just to focus on what's happening in the pancreas. But again, as a radiologist, one of the things that we pride ourselves on is that ability to look outside the box and think outside the box. If this patient is getting sicker, why are they getting sicker? Is it that the pancreas is getting worse? Or is it that there's something else going on? Another unexpected complication that nobody would maybe suspect clinically. And I've actually seen quite a few patients who develop sort of ischemia and perforation of the bowel just purely as a complication of pancreatitis, third spacing, and intravascular depletion, etc. So, as a radiologist, this is another thing that you will learn, is how to think outside the box and really consider other things that are going on. So for the next sort of 15 minutes, what I might do is show some other stuff. Let's have a look at this one. So this is something slightly different. So let's have a look at this. So we have lungs. What are we seeing in the lungs here? Well, even on the soft tissue window, you can see there's something going on in the lungs here. You've got these little funny nodules. Look at it on the lung window. You can see these nodules much more easily. Yeah, you can see there's another one here, the middle lobe there. You can see left lower lobe there. You can see lots of lung nodules, some of which are quite small. And then in the liver, we've got some stuff going on. What is going on there in the liver? Well, what did we learn? If you want to know what something is made of, you draw a region of interest over it. So here, this is a kidney. It's got something in it. Let's measure it. 11 Hounsfield units. That's between 0 and 20. What do we think that is? So 0 to 20 Hounsfield units is fluid density. Yes, absolutely. So that is a renal cyst. Nice, homogeneous, non-enhancing, fluid density, all good. That's a renal cyst. Now let's look at these liver lesions. Hounsfield unit value 50. What do we think those are? Is it fluid or soft tissue? Exactly, that's soft tissue. Yeah. So you've got soft tissue lesions in the liver. And in fact, it's not just solitary, it's multiple. Multiple soft tissue lesions in the liver. What are you already thinking? Particularly in view of the fact that we saw some soft tissue lesions in the lungs. Absolutely right, metastases. So you can see how these are the thought processes that you go through as a radiologist. You're looking at the lungs. Oh, there's some funny things in the lungs. You look at the liver. Those don't look like cysts. They look like soft tissue lumps. And there are lots of them. And already your brain is thinking Mets. So the next question is going to be, where are these metastases coming from? And you can see there's an absolutely enormous metastasis here in the right lobe, which is going all the way down into here. It's absolutely huge. So the next question is, where are these metastases coming from? So we've got lung metastases and we've got liver metastases. What would be common sites, common primary sites for liver and lung mets? Colon, absolutely. So that's probably going to be the first place you're looking for, right? So let's look at the colon, shall we? If you're going to be looking at the colon, usually it's easier to start in the rectum because it's always in the same place. So you can look at the anal canal and you can continue the anal canal up into the rectum. And you remember what colon should look like. Should be relatively thin wall, such as this. Yeah, nice, smooth, thin, regular wall with poo in it. And poo contains lots of gas bubbles and things like that. What do you think of the wall of the rectum as we're coming up here? I will measure the Hounsfield value as well to show you what that. So that's 60 Hounsfield units. And you can see, oh, sorry. So why metastasis rather than primary HCC? So the fact that you've got multiple lesions, both in the liver and lungs, makes you favor metastases. HCCs can be multiple as well. Obviously, you can get multifocal HCC, but just by probability, it's less common. I haven't talked too much about HCCs, but basically with HCCs, they also have a characteristic enhancement pattern. We don't actually have an arterial phase. If we had an arterial phase, HCCs, because they recruit blood vessels, they are hypervascular. So in the arterial phase, they enhance more than background liver. And then they wash out on later phases. So they then look lower density than background liver on the later phases. And that's characteristic for HCCs, whereas metastases, particularly from like colon cancer and that kind of stuff, are not hypervascular. So they will always be lower density than background liver, which is why when we're assessing the liver, we usually do a triple or quadruple phase to assess liver lesions, because some lesions are hypervascular, some lesions are hypovascular, and that particular pattern can help you in your differential diagnosis. I hope that makes sense. So if we're going further down, so rectum, you can see the wall of the rectum here is very thickened with soft tissue. If we're heading up, what are we seeing up against the pelvic side wall here? You can see that round lump. The lump contains some soft tissue, and it contains a little bit of some lower density fluidy bits. It's quite heterogeneous, isn't it? What do you think that could be? It's up against the pelvic sidewall. It's very asymmetrical. You can see on the other pelvic sidewall, you just have fat. What normally lives in this kind of area? Yes, lymph nodes, absolutely. So we've got rectal thickening. We've got an involved pelvic sidewall node. We continue up the rectum. You can also see beyond the rectum, within the mesorectal fat and the superior, along the superrectal vessels, you've also got a really big, irregular, look at this irregular shape. Sorry, my drawing's terrible, but really irregular shaped lymph node here, a superior rectal node. And also this lymph node contains little scattered foci that are over 100 Hounsfield units. What do you think these foci represent within that involved lymph node? It's over 100 Hounsfield units. Any thoughts? Yes, absolutely right. So that's calcification. So you can see how you can use the Hounsfield values to tell you so much about what you're looking at. There's basically little foci of calcification within that nodal disease. So we have a rectal tumor, we've got nodal disease. This node here contains some cystic necrotic bits. This node here contains some calcification bits and some maybe some necrotic bits. And then the other interesting thing here actually is if you're following the vessels, this is the inframesenteric artery, this is the inframesenteric vein, or at least a branch of it. If you look at that vein, as it comes here, the vein is expanded and actually stops enhancing like other veins. You see that? The vein here, you've got a branch that comes off there, and that branch then stops enhancing and expands. So what do you think that vein is full of? You can actually see it's a big expanded vein coming down towards where the tumor is. What do you think that is? Yes, so clot, absolutely. The fact that it's also expanded means that it's not just bland thrombus, but also it's tumor thrombus. So this is literally tumor growing into the vein, heading up. And this is something we call extramural vascular invasion, or EMVI. And it's something that we look for with rectal tumors particularly. Can get it in other colonic tumors as well. And this is quite literally tumor extending into a vein and going up the vein. And so how do you think this spread to the liver? Well, that'll be hematogenous. It could also be nodal as well, but it's most likely hematogenous, just given by the fact that you can quite literally see the tumor growing up the vein. And where's that vein going to go? Well, it's part of the portal system. So, of course, it's going to drain into the liver, which is why colon cancer spread to the liver. So this is a nice example of a colon cancer. Just out of interest, we talked about this simple-looking renal cyst in the right kidney. If you look at the left kidney, you can also see a lesion that is cystic. You can see Hounsfield unit value, roughly around about 20, but it also contains foci of calcification, and it also contains other areas which are soft tissue attenuation. So we've got a simple cyst on the right side, and we've got a complex cyst on the left with some soft tissue in it. As soon as you're seeing soft tissue within a cyst, you are worried that that actually could be a cystic tumor. And this is probably a cystic RCC, so renal cell carcinoma in the left kidney. Completely incidental. Yeah. But again, as a radiologist, you are looking for these incidental things, which, I mean, in this patient probably doesn't matter so much, given they've got, liver and lung metastases, but you're looking for those sort of little incidental things that you might pick up outside of the organ of your interest. So the next question is going to be, well, hold on a second. If they've got a renal tumor and a rectal tumor, how can we be sure that the metastases are from the colon and not the kidney? Well, firstly, the pattern of disease. Big liver mets, especially liver mets that look like this, big blotchy hypovascular liver mets, much more in keeping with colon cancer. Also, the colon tumor looks more aggressive because you've got loads of big nodes around it. You've got vascular invasion. You've got all features that tell you this is a very aggressive tumor. whereas the renal tumor doesn't look so aggressive. These cystic tumors are usually fairly slow growing and indolent. There's no venous invasion here, which is another thing that RCCs can do. There aren't any para-aortic nodes, which is where lymph nodes from renal cell tumors generally tend to go. So you can see how you can use all these little additional features to help you to come to a diagnosis and say, no, this is good metastatic colon cancer, and this is an incidental renal tumor. Do you see how I sort of came to that conclusion then? I hope that all makes sense. So for my final case, I'll show you, this is probably my favorite case that I've ever seen. Although over the years it has been challenged by various other cases. But this is a great case. So 20-year-old patient comes in with left-sided loin to groin pain, and they have an unenhanced CTKUB because they think, oh, it's renal colic. 20-year-old male, left-sided sort of flanky pain. Right, okay, renal colic. This is the kidney, obviously, is unenhanced. Obviously, if you're looking for renal stones, you don't want to give contrast because the stone is inherently dense, and you want that density to stand out against the soft tissue. So you don't want to give contrast, which is why CTKUBs are unenhanced. And there aren't any stones, but I mean, there's something really weird going on because there's this big old mass in the pelvis, which is like, what on earth is going on? There's something really weird going on here. And it looks like helter-skelter. What on earth is going on there? That's very odd, isn't it? So we were like, okay, well, let's now give some contrast. And also something weird going on in the chest too. So we gave contrast. And we did a CT chest up the pelvis. Clearly, this isn't renal colic. So what do we have here? Well, we've got a pleural effusion, as we've seen before. And then we've got this. Well, normally the chest contains lung. What's this in the chest here? We've also given some oral contrast, by the way, which is, sitting within these bits. Yes, bowel in the chest. Why would a 20-year-old have a chest full of bowel? Yes, so this is a congenital diaphragmatic hernia. Obviously, you can look for other causes like trauma and that kind of thing. This was not a history of trauma. So this was a congenital diaphragmatic hernia. And they've got a lot of their bowel sitting within their chest. Fine. Then we come down to the abdomen. So this is a portal face through the abdomen. You can see all these bowel loops up here. You can see stomach here. You can see liver here. You can see kidneys here. And then you come down and you've got this rather curious swirl coming down here. And then you come down to here. And then what do you think this mass is? What is its shape? I drew its sort of shape for you. What shape is that? It is related, just as a clue. Yeah, it looks a bit like a bean. Yeah, that's right. It's related to an organ that's missing. Because what organ do you normally see in the left upper quadrant? So kidney, yeah, bean shape, yeah, but both kidneys are accounted for. Yes, that is the spleen. The spleen normally lives in the left upper quadrant. But in this case, the spleen has moved all the way down into the pelvis. What do you think of the enhancement of the spleen? Is this a happy spleen? Normally, the spleen enhances like the liver. Is this a happy spleen or is this an infarcted spleen? May have given away the answer. Yes, that's right. This is a very unhappy spleen. So this is a spleen that is not enhancing. And as we've talked about those concepts, an organ that should enhance, that does not enhance, is an infarcted organ, or an ischemic one at least. So basically, this patient has a congenital diaphragmatic hernia. And normally, the spleen has ligaments that attach it to the left upper quadrant and keep it in place. But if you've got an absent diaphragm on that side, you can also have absent ligaments. And so what you end up with is what is quite literally called a wandering spleen. So this patient has a spleen that essentially is not constrained by any ligaments to the left upper quadrant. And as with anything else that's not constrained, it will wander around the place and it will move where it wants to. And this spleen moved down into the pelvis, then twisted on itself and cut off its own blood supply. And it's infarcted. So it's an infarcted wandering spleen in the pelvis. This is not something that any clinician would guess from an abdominal examination. This is something that you can only really make a diagnosis on imaging. And it's an absolutely fascinating case. And what makes it even more fascinating is understanding the anatomy. So what did we talk about when we were talking about the portal vein, the SMV, and the splenic vein? What did we talk about related to the splenic vein? What organ is closely associated with the splenic vein? Pancreas, absolutely. So we are going to follow the portal vein. So this is the portal vein here, comes across into here, right? And then you've actually got SMV heading upwards, supplying all these power loops into the chest. Splenic vein is obviously going to be coming downwards, right? Because we know the spleen is in the pelvis, and the splenic vein therefore has to go down to the pelvis. But the pancreas is stuck to the splenic vein, right? So this here is splenic vein coming down, and there's a bit of pancreas here. And so what do you think this swirly thing is here that's spiraling down towards the spleen? Yeah, you guessed it. That's the pancreas. So this here is a spiral pancreas that this patient has. And this spiraling tells you that the spleen is definitely torted, because the vascular pedicle of the spleen, which obviously contains the splenic vein and the pancreas, is also spiraling around and around and around. And not only that, but if you look at the pancreatic body here, you can see it's enhancing. If you look at the pancreatic tail, the final swirl, it's not enhancing. So it's not just the spleen that's infarcted, it's also the pancreatic tail that's infarcted as well. So, yeah, I mean, this is a pretty sort of remarkable case. But the thing about doing radiology is you see remarkable cases on a daily basis. I mean, quite literally, we see more interesting stuff in radiology than you would see in any other clinical specialty. And the reason for that is because I can show you all of the interesting cases. I've collected about 9,000 or 10,000 interesting cases over the years. I can show you every single one of them, and you can learn from them in the same way that I learned from them. Whereas if you've got an interesting case of, I don't know, infective endocarditis or something in AMU, once that patient's gone home, nobody else can see those splinter hemorrhages. Nobody else can see those really cool clinical signs. And so radiology lends itself really well to education because of the fact that you can see all of the interesting stuff that the consultants and senior registrars and other people have collected over the years. And you can learn from it in basically the same way that they did. And you can experience those cases firsthand almost. And that's what makes radiology training so much fun, because you can see so much interesting stuff. And as I said, more interesting stuff than you get in any other specialty. Because let's face it, who comes to radiology? It's always the interesting cases, the ones where people don't know what's going on. Nobody understands what's going on with the patients. What do they want? They want some imaging. So we get an unusually high concentration of interesting stuff within radiology. Anyway, I think that's my time over. I hope that was useful and interesting. Oh, sorry. Yeah, feel free to ask questions. I'm happy to answer them. How regularly do you find out about? So the other great thing is that I've got access to the surgical note system. I've got access to ICE. I've got access to electronic documents. I can look up clinic letters, and as time will go on, we will get access to more of these kinds of things. There's work also now to allow us access to GP notes as well. And so I can look this stuff up. I can look up histology reports. I can look up operation notes. So I've looked at this patient's operation note, and that's how I know what they found at surgery. So it's very easy nowadays to actually find out about what happens to these patients and to follow them up. So you always do that, which is also great. And the other thing you can do is you can actually look at previous stuff. So for example, I've seen cases where patients got metastatic disease and they can't find the primary. And whenever you can't find the primary, you always think melanoma because you can't see skin cancers very well on CT. So I've then looked, and also the other thing melanoma does is it often recurs 10, 20, 30 years after the original diagnosis. So then I've looked at ICE and I've looked back several decades on ice to look to see if they ever had a histology report that showed melanoma. And in probably 5 to 10 cases I've had over the years where I've identified that yes, the patient did have a melanoma 15 years ago, and therefore this is most likely metastatic melanoma, and that's been proven true. So you really have the opportunity in radiology because you do have time. You're sitting there on the computer. You don't have a patient in front of you. You do have a bit of time to actually look and investigate and do the Sherlock Holmesing or the House sort of work. If any of you have watched House, it's a bit of an old show now. I'm not sure whether any of you have watched it, but honestly, it feels like being Sherlock Holmes, going through and investigating and finding out sort of what's happened to the patient. Sometimes you end up with more clinical information than the clinicians have. So anyway, there we go. Any other questions before we finish? Great. Thanks very much. Thank you.